If medical science can discover a vaccine for a hitherto unknown coronavirus and roll it out in record time, then how much else is possible? On World Cancer Day 2021, some good news and some bad news. The good news is researchers did not wait for COVID to raise their game. We'll ask about promising innovation in immunotherapy, even, yes, vaccines to fight cancer. That's right, huge leaps forward in both treatment and prevention. We're going to need it. The bad news is that as life expectancy rises and humanity moves to the city where the air is polluted and the food is processed, the number of cancer cases will continue to skyrocket. How to reverse the trend? Has the past year set back the fight against cancer, what with medical staff overwhelmed by COVID and funding harder to seek? Or has the pandemic reminded us of the value of science and the need to support it? Perhaps we've even stumbled upon new ideas. Today in the France 24 debate, we're asking, are we at the dawn of a new era when it comes to the fight against cancer? And joining us from Geneva, Bente Mikkelsen, Director of the World Health Organization's Non-Communicable Disease Department. Thank you for speaking with us.
Having me, and happy World Cancer Day.
From Birmingham, England, Kapoor Yip, Clinical Research Fellow at the University of Birmingham's Research Laboratories. Welcome to the show.
Thank you very much for having me today.
From Kenya's capital, Dr. Andrew Odhiambo, medical oncologist and lecturer at the University of Nairobi. Thanks for being with us.
Thank you very much.
And from Dallas, Texas, science journalist Tara Haley. Welcome.
Hi, thanks for having me.
The France 24 debate on Facebook and Twitter. Hashtag F24debate. This is France, so we have a mandatory clause in our contracts to brag about the Nobel Chemistry Prize when the winner is French. This past year's winner, Emmanuelle Charpentier, sharing the prize with Jennifer Doudna of the United States for the development of CRISPR, a gene editing tool that's revolutionized cancer research treatment. That tool has a nickname, Genetic Scissors, perfect for easy, pinpointed tinkering with DNA.
I also think of all my colleagues of the CRISPR field and all the scientists who have really done a fantastic job to bring this technology further that allows now to have a genome engineering technology, a very versatile one that is used by multiple scientists all over the world to modify genomes of cells and organisms.
Bente Mikkelsen, when she made that statement back in October, she pointed out that normally you get a Nobel Prize 20 or 30 years after whatever thing you did. This time, it's only been 8 years. You get a sense when you look at some of the innovation around cancer that things are going fast.
Yeah, that's true. You know, when you speak about innovation and fight for cancers, these are really the field of the greatest innovations. If we look at the research, approximately 47% of all pharmaceutical research is on cancer. But I would like to add, you know, I think when we discuss cancer, we have to be really comprehensive. Today, almost every family of the world is having an experience with cancer. So this is really a shared international experience. So when we look at cancer inequities and what it takes to really build a system for cancer, it is, of course, about pharmaceuticals, but it is definitely about including cancer patients into the universal health coverage system in every country and build health systems. So it's much more than the pharmaceuticals.
Much more than the pharmaceuticals. I mean, things like immunotherapy, how much do they offer a chance to, I know there isn't one type of cancer, obviously, and one type of treatment, but to wean ourselves off of those heavy treatments, things like chemotherapy?
So again, it's very, very encouraging what we see, and WHO, of course, are including on the essential medicine list the cancer therapies that we can, provide. So many of the things like the targeted therapy that started more or less in 2015 is now included. Immunotherapy is also, considered, and so on. But again, what we really need is to prevent, to screen, to early detect, and to build health systems to really take care of people. And this is what we have disclosed now during COVID as well. When the health system are broken or occupied with other business like COVID, the one who suffers is the people in need of chronic care and diagnostics like cancer patients.
I want to talk about prevention because that's obviously fundamental to this discussion. But Andrew Odhiambo, first, have you your firsthand experience working as an oncologist, have you seen this innovation come to fruition fast?
Thank you very much for that question. So in Kenya, we have started using some of these newer medications, but obviously they cost quite a bit of money, and majority of the Kenyan population cannot afford these new innovative treatments. Majority of the patients still present very late with their cancer. Many of them are having trouble even accessing diagnosis, but the few who are able to afford, for example, immunotherapy, are able to get it, though the numbers may be few. I'd like to agree with the previous presenter that we need to build health systems and we need to focus on prevention and early detection.
Kepor Yip, your thoughts, your reaction.
I completely agree, because I think even though we have new promising treatments out there for various types of cancer, I think in essence, prevention is better than cure. So I think we, like has been said so far, we need to have health systems that not only help detect cancer earlier and therefore have a better treatment rate for it, and indirectly that would hopefully drive down the number of cancer-related deaths, really.
And for this, we're going to talk about prevention, but already I just want one final word on treatment. For World Cancer Day, the World Health Organization announcing figures this Thursday. Globally, breast cancer, by the way, has overtaken lung cancer as the most common type. Yet, if you look at a graph with the list of the deadliest cancers, you'll note how since 1990, the mortality rate for breast cancer has slightly decreased. So the conclusion, I guess, Tara Haley, you can draw from that is that treatment is becoming more effective.
It definitely is. It's pretty remarkable. When I cover cancer for different outlets and I attend the conferences, it's kind of mind-blowing how rapidly it's moving. And I think that's a combination of both understanding how different cancers are, but also the genomics that we're learning about. As we learn how different genes affect the progression of different cancers and the causes of different cancers, there's treatments that can be developed to target those specific genes. So the ability to learn more about those genes and the different sequencing of people's genomes when they have cancer has been a huge help to that. Like I said, it's a bit mind-blowing how fast it's moving, but when I speak to people across the board in different researchers across the board, even for cancers that have been traditionally very difficult, such as pancreatic cancer or glioblastoma, they are always very optimistic. And that optimism has increased in recent years. And I don't think it's just false optimism. I really do see a lot of progress in finding ways to not only address the actual symptoms of cancer, but allowing people to live longer with cancer, even if it can't be cured.
And you heard earlier Dr. Odhiambo express concern about whether these new innovations are affordable for his patients. Tara?
Oh, I'm sorry. I thought you were asking somebody else. I apologize. Could you please repeat that question?
Yeah, you heard Dr. Odhiambo express the concern about whether or not these new innovations are affordable enough for his patients. Your thoughts on that?
That's probably the biggest barrier in general in cancer treatment is equity. And it's a problem across healthcare. It's not specific to cancer, obviously, but I think it has a bigger impact in cancer because cancer affects so many different populations across the world. The immunotherapies in particular and the targeted therapies are generally, most of them are developed in highly developed, high-income countries, such as the United States and various countries in Europe, and they do not tend to be affordable. And I wish I knew what the solution to that was. I think subsidization is a part of that, but I think we need more interaction and more collaboration between the companies between the countries whose companies are developing these treatments to find a solution to that, because it should not be a situation where only people who live in the richest country have access to those treatments. It needs to be equitable across the world, and it definitely is not the case right now.
Bente Mikkelsen, it's an old chestnut what we're discussing here. The pharmaceutical companies or the labs that roll out these new innovations, well, they say we are the ones who took the risk and spent the money on research. We have to make our money back. What do you say about this problem?
So we know that new cancer drugs are extremely expensive, but what we are looking at, as I was mentioning, one of the measures that WHO provides is to assess existing drugs. And the good news is actually that the existing, you could call them old therapies, are included in the essential medicines list, and these are the more affordable medicines as well. But I totally agree. We have an ongoing discussion on how to sort of change price structures, how we can increase equity in cancer. But that goes for the whole sort of pathway for the cancer patients. So from sort of the early detection, screening, the technology available, the workforce, and the health system in total. So again, it's huge inequities, as was mentioned by Tara, but it is due to many of the different things. So I think it's very important that we focus on the drug side and the technology side, but we cannot be able to do this without having the full sort of comprehensive view and look at all the inequity factors.
And sitting
but the good news.
Go ahead.
The good news is still that, you know, we have identified therapies, and these are sort of described and available on the essential medicine list. And this is one of the ways that the countries, even the low-income countries, can use this as building blocks in their cancer therapies.
And Dr. Odhiambo, looking where you're sitting in Nairobi, you get the sense there really is an urgency to all of this. I saw a report that the number of cancer patients in the Kenyan capital is rising sharply. And what's a little unsettling is why are there so many that are young, under the age of 50?
Thank you for that question. And it's a very interesting observation that we have seen our Kenyan cancer patients the sort of top 10 cancers have evolved over time. If you look at the country statistics, maybe in around 2010, we didn't have much of stomach cancer, much of colon cancer, and esophageal cancer. And these three cancers have really become more prevalent in the last sort of 5 to 10 years. If you're looking at the latest Globocan data for 2020, you would find colon and stomach cancer are now in the top 5 most common cancers in Kenya. And we are seeing them in a much younger population, probably 10 years younger than the average population in the US or in Europe. We are still yet to understand what could be the causative factors, but we imagine it could be something that we are ingesting with or without our knowledge, or it could be something that is different in our genetic sort of makeup. We are still very early in the epidemiological studies trying to find out why these cancers are becoming more common and why they are afflicting a much younger population. I guess with time, maybe with more research from the main reference laboratory, we'll be able to find out why these cases are rising at such a fast rate.
Gosh, it's a startling increase. Kapor Yip, when you look globally, there's talk about, a cancer epidemic around the globe? I don't know if that's the right term, though, to use.
No, it's will be a bit difficult to assess. I think partially the fact of these observations partially got to do with what's happening over the last 2 years, really, in terms of what COVID-19 has started. As you know, cancer services have really been shot down, really, by the fact that the pandemic has raised its ugly head, really. So I think it has partially got to do with the surveillance of cancer services. So I know here in the UK, what usually happens if patients come in with symptoms that could resemble cancer, they get sent as an urgent referral to hospitals to undergo diagnostic tests. And now, I think partially because of what's been happening, that has not been smooth sailing over the last year or so. And I think we are kind of playing catch up at the moment to diagnose cancers that are ongoing and treat cancer cases. Anecdotally, I've seen when I've been working on the wards in the hospital where I worked in Queen Elizabeth Hospital, Birmingham, I realized that there's been more cases that have been diagnosed at a much later stages, partially because people have been afraid to present themselves in hospital. But that's a problem that we'll have to tackle in the near future, really.
When we come back, I'll ask you whether or not that was a one-off because of the lockdown in March, or whether this is there's something more to it. Stay with us. You're watching the France 24 debate. Welcome back, or welcome if you're just joining us. It's the France 24 debate. We're looking at World Cancer Day, at prospects, new hopes, what with the innovations we've been discussing in the fight against cancer, most notably when it comes to things like immunotherapy. We're talking about it with, from Geneva, Bente Mikkelsen, Director of the World Health Organization's Communicable Disease Department. From Birmingham, England, Kay Poor-Yip, Clinical Research Fellow at the University of Birmingham's Research Laboratories. From Kenya's capital, Dr. Andrew Odhiambo, who is medical oncologist, lecturer at the University of Nairobi. And from Dallas, science journalist Tara Haley. Welcome back to all of you. Just before the break, Kay Poor-Yip, I was about to ask you, you have noticed, and I know you've written about it, the incidences of how COVID has disrupted the fight against cancer. And you're saying people coming in for their first diagnosis at a later date than usual. Is it just because of the fact that people were in lockdown in March and April?
I think that has, one of it has got to do with lockdown issues. I think when it first started back in March, not much was known about the disease back then. So there was a lot of hesitancy from health regulators, really, to know what the effects are basically on people receiving cancer treatment and cancer therapies. But also, I think when it first started, people generally have been afraid to come into hospitals, for example, for fear of catching COVID-19. Now, that has definitely disrupted cancer services and in terms of people coming to hospital quite late, at a later stage. I think with the situation evolving just right now, we will continue to see whether this has been happening as well during the latest wave, really, in the UK. So only time will tell.
And there's a second issue now that's arising. When you have recovering cancer patients with their weakened immunity who are in a hurry to get the vaccine now that it's out on the market. It's a France 24 report by Chris Moore.
Every week, Delphine comes here for chemotherapy. But as well as living with cancer, she now lives in fear of COVID. The risk of contracting a severe form of the illness means she's had to make major changes to the way she and her 7-year-old daughter interact socially.
On a peur mutuellement, autant elle de me donner le virus et vice-versa. Donc on ne voit pas beaucoup de monde. Par exemple, d'aller voir mes collègues de travail, aller boire un café avec elles, ça me manque énormément de retourner dans mon établissement. Et c'est vrai que là, je me l'interdis. Le vaccin, c'est un espoir. Et c'est surtout pour nous protéger, nous, et l'entourage. Et puis revivre, quoi.
It took more than a month of negotiations for health authorities to give the green light to doctors demanding the vaccination for cancer patients. In the Sainte Catherine Institute in Avignon in the south of France, medics are making sure the process is properly supervised and patients' treatments adapted.
C'est ça qu'on vous propose de faire. Vous avez une analyse faite à la maison, je la récupère, je regarde et je vous dis vous êtes plus protégé, c'est bon, et il faut simplement resurveiller le taux d'anticorps après. Et si jamais votre taux baissait, ça peut être une troisième vaccination, une troisième injection derrière, ce que n'ont pas prévu pour l'instant les pouvoirs publics encore.
But doctors say they can't guarantee results, estimating the effectiveness of the vaccine on cancer patients at just 30%.
Ce qu'on ne sait pas, c'est est-ce que le vaccin va être efficace, par exemple, chez un patient qui est en cours de chimiothérapie. Il se peut que le vaccin ne fonctionne pas parce que l'immunité en cours de chimiothérapie est altérée. Les mécanismes qui font l'activation de l'immunité contre le virus peuvent être altérés. C'est surtout ça, la zone d'ombre.
The Pfizer and Moderna jabs claim 95% effectiveness, but clinical trials didn't focus on immunocompromised patients. Despite the uncertainty, the Sainte Catherine Institute has been told it will get the vaccines it needs. The campaign here is set to last several months, with 20 to 40 patients injected per day.
Okay, so Bente Mikkelsen, if you have your body working, your body's immune system working in overdrive because you're in chemotherapy, they're not sure if the vaccine is as effective, and you heard that doctor wonder, will they be allowing us to give out a third injection if need be with some of these vaccines? Is that something that's being talked about at the WHO?
So we have some research going on, so I don't think we can conclude on this. What we know is that there has been what we call a deadly interplay between people with non-communicable diseases, meaning cancer, diabetes, cardiovascular diseases, and lung diseases. And this is due to many things, and we still don't know the excess mortality either. But what we have seen that people with these diseases have been more, frequently dying and getting severely ill. We know that, as also these reportages tell us, that we have delays in treatment, and also they have been more unprotected when it comes to prevention, and also less access to medicines. So when we have surveyed the countries, and 83% of the countries has answered these surveys, we see 50 to 60% disruption in health services. So again, when it comes to vaccines, there is ongoing research, and when it comes to the situation for people with cancer, we know that they are at a greater risk, and this is something we really focus on in the national preparedness and response plans as well.
All right, we talk about the COVID vaccine, but they're also talking about vaccines against cancer, one most notably which targets cervical cancer. Infections known as, I hope I'm pronouncing this right, human papillomaviruses, often sexually transmitted, are now in the crosshairs of the European Union. Let's listen to the health commissioner.
We aim to eliminate cancers caused by the human papillomaviruses, and we're proposing support for member states on vaccinations with an aim to vaccinate at least 90% of a target population of boys and girls by 2030. And this will create, this is real prevention.
So, Bente Mikkelsen, again, we're back to talking about innovation here. Can we expect more and more vaccines to prevent cancer?
So first of all, I think what the commissioner is saying here is really good news, and this is one of our signature solutions. Cervical cancer is the only NCD and cancer that we know that we can eliminate. So it is fantastic news today that the European Commission is really investing into this. So this is what we want to see all over the world, 90% of the girls vaccinated. So this is the first one we know is effective. And I think we need to at least, fully implement what we know. So this is the elimination project or initiative for cervical cancer. We have a couple of others as well, as was mentioned briefly. We also have a global initiative for childhood cancer that is not about vaccination. And we also today launched actually a new signature solution for breast cancer. So happy that you're focusing on this. And I think we now see more and more member states, the countries investing in this vaccine. So that's good news.
Tara Haley, here in France, I'm over 50, so I've gotten the little kit for free to send back to check for colon rectal cancer. I'll spare you the details of what that consists of, but is it the same in the United States?
I'm not aware of at-home testing. Usually for colorectal cancer, you have to schedule an appointment for your for a screening that you go in for. So I'm not familiar with that, but we do have the U.S. Preventive Services Task Force that they issue all of the different recommendations for screening for different populations. So there is routinely recommended screening for colorectal cancer among people over age. I think it's also over 50 here. Don't quote me on that. But the U.S. Preventive Task Force is basically the organization that determines what most people follow and what most insurance companies will cover in terms of cancer screenings.
And Tara, do you have a crystal ball with you? What does it say regarding vaccines?
In terms of cancer vaccines or the COVID vaccine
Cancer.
Which one?
In terms of cancer.
The cancer vaccines, I mean, there's been a lot of progress on it. I haven't looked as much at the therapeutic vaccines because there's two different types of vaccines. There's prophylactic, where you prevent something from happening in the first place, such as the HPV vaccine preventing HPV-related cancers, or the hepatitis B vaccine preventing liver cancer. The most of the cancer vaccines, however, are therapeutic vaccines, where you give it to someone after they've already developed cancer. I know there's been a lot of progress on it. I don't believe any of them have been approved yet. I'd say, based on what I've looked at, I could see at least one of those being approved in the next 5 years. I don't think there's any approved yet. But it's a weird space. I haven't followed it closely enough to give you a strongly educated answer on that. But I do think it has a lot of promise, and it is, that research is continuing in a positive direction.
Kapor Yip, again, COVID means that the whole planet now is a lot more aware of what vaccines are. Again, is that going to influence the fight against cancer?
I think generally it will, because saying that, like the Gardasil vaccine you were talking about, I suspect that like this will bring vaccine to forefront news, and then and thus people will be more aware of vaccines and its beneficial effects. So I'm hoping that this will bring into limelight the fact that there are cancer vaccines out there and there are ways to prevent it. Now, Gardasil itself to prevent cervical cancer is a good start because cervical cancers were like was mentioned one of the small areas of cancer where human papilloma virus is actually known to cause cervical cancer. But yes, I would say it would hopefully increase uptake, and I think, like was mentioned already, the announcement by the EU Commissioner was well received, really.
All right, here in France, the government announcing more traditional prevention measures this Thursday for World Cancer Day. The President, Emmanuel Macron, visiting a cancer treatment center in the Paris suburbs, where he pledged to do more to help citizens cut down on smoking and drinking. And again, Dr. Andrew Odhiambo, we were asking you in part one about the spike in cancer. You were cautious about specifics since not all the research is back. But your reaction there, I mean, how much of it is down to smoking and drinking?
Thank you very much for that question. So in the Kenyan population, we don't have very high rates, for example, of tobacco consumption, cigarette smoking, or alcohol intake to influence development of cancers compared to the US and Europe. We actually think our risk factors may be different, especially because we are seeing a much younger population getting cancers that have traditionally been thought to be because of exposure to long-term cigarette smoke and long-term alcohol consumption. But we are getting patients with lung cancer who have never smoked. We're getting patients with throat cancer or esophageal cancer who have not had any exposure to tobacco or alcohol. So we think that our reasons might be different. Though we have an upcoming population of the youth who are indulging a lot in alcohol consumption, and maybe this might represent the spike in the cases. If you look at the 2040 estimates, we're probably going to be seeing many more cases of breast cancer, many more cases of lung cancer, pancreatic cancer, because of the young population who are indulging in a lot of alcohol and cigarette smoking.
And are you talking about Nairobi specifically, or is this all of Kenya?
I guess Nairobi will be representative for majority of the country, but we have some slight regional differences in terms of cancers that are prevalent. We have some areas that are harder hit by different types of cancers. For example, in the northern part, the northwest part of Kenya, we have a very high incidence of esophageal cancer for reasons that we cannot readily explain compared to the southern regions or the coastal regions of the country.
What are the possible explanations? Is it something in the diet? Is it the fact that people are not living as healthy as a lifestyle as they used to?
I think it's many reasons combined. I think for majority of African countries, and Kenya included, our ability to diagnose or our ability to pick up these cancers has really improved over a short duration of time, whereas previously we didn't have widespread, for example, technology like CT scans or endoscopy in the rural areas. Now we have those services available in the rural areas, and we're able to pick up cancers that before patients would die without knowing that they actually have the cancer. So our ability to diagnose has really improved. Our control of HIV has resulted in a population living longer than they normally would have. So we are getting a bigger pool of older patients who are generally more predisposed to getting these cancers.
Bente Mikkelsen, you agree?
So I think, Macron has a very good point, and this must never be forgotten. The most important is actually to do, what the motto of the Cancer Day today is, I will and I can. Because if you quit smoking, if you have a healthy diet, if you do regular physical activity and also avoid harmful use of alcohol, you are in a very good place. And if your authorities, in addition, could reduce the level of air pollution, we are in a very, very good place. And then if we add the two vaccinations, as you were speaking about the hepatitis B and the HPV vaccine, then we have done almost the maximum. If we should add one more thing, and this is a little bit sort of different from region to region, but most regions should also avoid prolonged sun tanning. So, but tobacco and physical activity, diet, and to avoid harmful use of alcohol is something we can do, all of us. So definitely, Macron had a very good ideas if this was what he was focusing on today.
All right. When you talk about cancer, something else that's been impacted by COVID is fundraising. We've been watching the tributes from this side of the channel after the passing this week in the UK of Captain Tom Moore. He'd been recovering from skin cancer during that first confinement when he shot to fame, walking at the age of 99 in his backyard to raise money for the National Health Service. Among the creative initiatives for World Cancer Day this year, we saw the Solidarity Challenge, where UK Olympic runner Mo Farah was on a treadmill and he beat out sports stars on stationary bikes to raise money in a virtual race. We're always Kay Poor-Yip in admiration at the British because they're so creative when it comes to fundraising. More seriously, though, is it a big problem, the fact that the attention hasn't been so much on cancer this past year?
That's not only the past years. Sorry, was it the question for me?
I'll put it to you, Bente, but I'll put it to Kay Poor-Yip as well. Go ahead first.
Okay.
Kay Poor-Yip.
Oh, sorry. Yeah. So I think, in a sense, rightfully so, our first initial response was to prepare for the first wave pandemic. I think, like it was mentioned before already, it caused quite a lot of people with what we call non-communicable disease, like cancer, to be kind of largely, in a sense, ignored. And I think, in a way, it's a bit of a shame that we've kind of failed them to some respect, and we've had to, and it's very encouraging to see members of the general public, like Sir Captain Sir Tom Moore, who managed to use his innovation to raise so much money for the NHS. But I think this not only you have to be aware that not only you have to prepare for, and treat people who've had COVID-19, but we cannot forget about the other people who have other diseases as well. And I think that's an important lesson to remember from the first wave itself. That's from my opinion.
Let me get a final word from Tara Haley on this, because you have a new president, I see, in the United States, and he says that science is back. Does that mean that there's going to be more of a focus now on funding and, the importance of science?
I certainly hope so. We've been in the dark ages for 4 years. It's been quite frankly hell. Science has suffered. Everything has suffered. Human rights have suffered. And our new president has quite a big task ahead of him. He not only has to undo a lot of the executive orders that were done and a lot of damage that was done, but he also has to sort of reset the course on a lot of things where it just went awry. And I definitely think that including science is one of them. Unfortunately, we're out of time, but I want to thank you so much, Tara, for joining us from Dallas. I want to thank Bente Mikkelsen in Geneva, Kay Poor-Yip in Birmingham, and Andrew Odhiambo in Nairobi. Thank you for being with us here in the France 24 debate.